we will invite all our speakers to the podium. We have only 5 questions. دكتور اسلام دباب سأل.
Good evening for you, and thank you for all of the lectures. My question is for Professor Muhammad Hussein. Khalid, that's it. Despite you show that only one patient in Qatar with Didmoid, with Wolfram syndrome, only one patient is present there in Qatar. But my question is how to prevent the disease in his brother or sisters, because I have in my life practice a family, 3 or 4 brothers with Didmoid or Wolfram syndrome, and it is very painful for the family and for the doctor to deal with these patients. Thank you.
Thank you for the question. I agree, it's a horrible condition. I mean, you can do prenatal testing. So in your cases, do you know the molecular diagnosis? Do you know the... No? So what we can do, I mean, this is the whole point of these meetings. I mean, Abid, we are very keen to establish collaboration to help the molecular diagnosis. We have a laboratory that can actually assist on a research basis to help people like yourself who want to do molecular diagnosis. Free of charge, no money, nothing, but on a research collaboration. So if you have a molecular diagnosis, you can do prenatal testing in your patients. That's one possibility. But you can't prevent the disease yet, because you cannot prevent it yet, because it's a recessive condition. So mother and father are carriers. So the child has 25% risk. But you can do prenatal diagnosis. That's possible, and then you can plan whatever you want to do after that. But first, you need a molecular diagnosis on your patients. And I'll be very happy to help Abid in establishing a collaboration to help with molecular diagnosis on a research basis. No money involved, free of charge.
If the disease is established, you can deal with these patients?
Yes, of course. I mean, the most important complication is diabetes and diabetes insipidus. Yes, you can't prevent the disease because the disease is there. I mean, there is no medicine at the moment that can prevent the disease. We can treat the complications, but at this moment in time, we cannot prevent it. At the moment. But who knows in the next 5, 10 years.
Next question.
Obviously, the question is for Khalid. I appreciate it. Very good presentation. I have a couple of points that I want to raise. The first one is you show that some of your patients with type 1 were antibody negative. These are very interesting patients. So the question is the age of these patients, because normally small children may not have autoantibodies. And I wonder if you have started facilities to study the molecular biology of some viruses, for instance, Coxsackie, because there is a Finnish group has demonstrated that some of these patients have aggression of beta cells because of the viruses, particularly some strain of Coxsackie. And also, the second point that I want to raise is about zinc transporter. We also already discussed about that, because I had the opportunity to meet the opponent of a dissertation, of PhD dissertation in Helsinki, Finland. And they were presenting, in fact, the value of these zinc transported antibodies. And you show that some of the patients may have zinc transported positive, although the other antibodies are negative. So I wanted to comment if you think that in the screening of type 1 diabetes, we should include the zinc transported antibodies.
So I'll start with the last question first. There are now studies from Turkey, for example, where in most of their patients, zinc was the only antibody positive. All the other antibodies were negative. In our patients, in some of them, zinc is present at a very high level. What we're doing now is testing the normal population to see if zinc is just present in normal people or not. So hopefully the data will become very clear. So I think it's important, at least if you can measure zinc, you should measure zinc. In terms of the antibody negative, we've now got 30 patients. That was the slide, not updated. But there are now 30 children aged between 2 and 18 years of age with antibody negative type 1 diabetes. This has been reported before. This is not a new observation. But people don't know what the molecular mechanism. We don't know. How can you call them type 1 if there's no antibody? There must be another mechanism, another immunological mechanism. In other words, new antibodies may be present.
Maybe another antibody.
Yeah, another antibody or some other molecular mechanism. So that's our immunologists are now working. Our immunologists are now working on these patients at the molecular level in terms of immunology to see if there are other proteins that may be involved in damaging the beta cell. And your last question in terms of Coxsackie, yes, there are quite a few studies suggesting that enteroviruses and Coxsackie viruses may be the trigger for type 1.
Not all strains.
Some strains, absolutely. I mean, we are not specifically looking at infection at the moment, but that's something that can be done in the future.
مساء الخير. السؤال موجه للدكتور جمال. بالنسبه للعلاج بالستيم سيلز، قد ايه انجكشن نعطيهم للمريض؟ يعني النظام العلاجي ازاي بالنسبه للبيتا سيلز انجكشن؟ كل قد ايه بنعطي؟
احنا بنتابع الحاله. اول جرعه بتكون يعني يوم ما اجانا المريض، الجرعه اللي بعديها بتكون ما بين شهرين لثلاث شهور. بالطبع احنا بنتابع ثلاث امور مع المريض اللي هي A1C كويس، السيبيبتيد والسيبيبتيد والكرياتين. اوكي، بنتابعهم مع المريض. وكل ما بنضلنا متابعين كيف بينزل المستوى التراكمي. بعد 3 شهور بنحدد الجرعه اللي بعديها. الجرعه اللي بعديها ممنوع تكون قبل 6 شهور حتى الخلايا الجذعيه لانها جاذبيه تنقسم بالكميات النهائيه الكافيه لها. الجرعه اللي بعديها بتكون بعد 9 شهور. الجرعه اللي بعديها بتكون بعد 9 شهور. يعني اليوم، بعد 3 شهور، بعد 6 شهور. كويس، المريض بنستمر مع المريض حتى التخلص من العلاج. في طريقتين لادخال الخلايا الجذعيه، بنعطيهم بالوريد بالفين اي في، او نستخدم اللوكال انجكشن في البنكرياس. بس في إلها سايد ايفكت اللوكال انجكشن، انه قد يحدث عندنا نكروزيس في البنكرياس. علشان هيك في العالم كله تقريبا ابتعدنا عنها شويه. قبل ما اجي وقعنا مع السويد ومع اسرائيل انه نستخدم السيل عن طريق الانجيوغراف، يعني اندوفاسكولار. ندخل عن طريق الاندوفاسكولار ونجكتد في البنكرياس مباشره. نفس الطريقه بنستخدمها الاي ام. لمرضى الاي ام نستخدم الانجكشن ستيم سيل مباشره في عضله القلب في مكان الانفاركت.
Last question.
Thank you. Professor Khalid, you talked about a group of patients that were autoimmune positive and with type 2 diabetes. Did you treat them? Did you follow up them? How did you counsel them?
So at least the double diabetes, is that the one? So obesity with antibody positive, is that the one you're asking about? Yeah. I mean, they're managed with metformin, but after listening to some of the people here, I'm probably going to give them something different, because metformin doesn't seem to be working with them. Some of them need insulin as well, but it sounds like they need new therapies, because the HbA1c is still high despite metformin and insulin. So new treatments will be appropriate.
Just to comment on this, there has been that today's study done in the United States. Hundreds of patients were followed, type 1 diabetes kids, were followed for 10 years. 2 things we learned. One, Yeah, type 2, that's what I said. Type 2, kids, type 2 diabetes, followed for 10 years. That was a typo error. So we learned two things. One, the disease in the kids is very aggressive. We have already in the 20s, the kids in the 20s, 2 cases of CVAs, myocardial infarctions, and cardiovascular death, and renal failure. Secondly, they are not responding nor to metformin, neither to metformin nor to SU. The most recent study that shows the most effective, and now they get approval in type 2 in children, is liraglutide. In the study, rosiglitazone tried was better than metformin, but now what get approval from the FDA is liraglutide based on a study that was just published this year in the New England Journal of Medicine.
This is what we're going to try.
We have one question and one comment.
I'm a pediatric oncologist, and I'm aware of doing hematopoietic stem cell transplant in children. I'm a pediatrician. So my question is to Dr. Debabse, please, about evidence-based use of hematopoietic stem cell and neurometabolic disease in children. And we know that this is a curative treatment for children. But if there is any evidence base for using stem cell in some neurometabolic disease in children, and if you have any experience, you can share with us, please.
بالبداية إذا كان الطفل لعمر 5 سنين ممنوع استخدام الخلايا الجذعية ولا بأي طريقة. أقل من 5 سنين لأنه الإمبريونيك تيشو لسه موجودة في الجنين بالطفل. يعني after delivery ب5 سنوات لسه ممكن نلاقي إمبريونيك تيشو في الجنين. فعلشان هيك جنين طفل أقل من 5 سنين ممنوع استخدام الخلايا الجذعية. بعد ال5 سنين عندنا لحد سن ال16 اي نعم استخدمنا الخلايا الجذعيه. استخدمنا الخلايا الجذعيه. أوتي. FDA it's accepted treatment for 3 diseases. Okay. Neuro cell, pancreatic cell, and skin cell. It's FDA.
No strong evidence. In type 1 diabetes, if you use stem cells, you get nothing in terms of remission, long-term production of insulin. That's the problem. So we should say the truth to the family. There is no cure for type 1 diabetes in children, because otherwise, people are coming to Ukraine to get stem cells for
to get free of type 1 diabetes. This is not fair. I mean, if you would, I do hope that one day the stem cells can actually solve the issue of type 1 diabetes in children, because it's such a nasty disease, for lifelong nasty disease. So please do a randomized controlled trial in order to actually show that if you get stem cells in the very beginning of the disease, you get free of insulin. That's the very point.
This is what I told. We didn't told that we treat the disease. We cover the body. We cover the body. We don't.
Family cannot afford.
No, if you told the family that your child will have after 5 years or 10 years have problem with the kidney, with the eyes, with the legs, okay, and need to take the stem cell to cover his body, he will accept. Okay, and not only in Ukraine you can make stem cell. Here, 20 kilometers from here you can make, but it's expensive.
In Italy is not allowed. In Italy is not allowed. The Italian medicine agency did not accept, did not approve any stem cells treatment.
We the same, we didn't accept. 5 years we didn't accept.
Okay, thank you. Our dear guests, lecturers, thank you for this session. We have to move, please, a quick coffee. We have to move for the last session and to continue after Friday. Please drink it within 5, maximum 10 minutes. We have to move for the last session, 2 lectures, and you will go home. Please stick to the time and come back quickly. Thank you.